welcome to The Wellness. My name is Candy Nicholas, and I'm your host for today. And we're going to be speaking with Dr. Tamara Remy. She is the president of the St. Lucia Cancer Society. She is a general surgeon, and she's also a member of the American Society of Breast Surgeons. And we're still in Breast Cancer Awareness Month, which is a month where we focus on just talking about breast cancer. What are the risk factors? What are some of the things that we can do to prevent it, among a host of other things on the topic? And I thought she was the best person to have that discussion with. So welcome to The Wellness, Dr. Remy. It's such a pleasure to have you here.
Thank you. Thank you so much for having me. It's my first time on your show.
Yes, I'm excited. I think we tried to do it before and it didn't happen.
Exactly.
So nothing before it's time, as the old people say.
Exactly.
So it's Breast Cancer Awareness Month. What does breast cancer look like in St. Lucia? What are the statistics? I know, I read somewhere recently that it was the second leading cause of death in St. Lucia. Is that correct?
It's the #1 cause of cancer-related death in St. Lucia among our women. And yeah, it is the most common cancer among women in St. Lucia. And unfortunately, our numbers are not going down. They continue to increase. And we really are no different from the rest of the world in seeing the increase just in the number of cancers generally. And unfortunately, younger and younger women are getting breast cancer. And the focus really, why breast cancer is so important is because half of the population is female. And I say that, but also need to add a slight note, a short note, that it doesn't only happen in women, but men do get breast cancer far less uncommonly than women do. But if we think about it, if half of our population is female and it's the #1 cancer, and we understand the significance of the woman in society, the significance of the woman in a family, then we understand that once we have a female who has been affected by breast cancer, there's so many other aspects that are also influenced, you know, the family cycle, the circle, workplaces, just society on a whole. And we're seeing increases in mortality. And when I say mortality, we're talking about death. And even for those persons who don't die from breast cancer or cancer in general, there are the effects of the treatments, the disease, you know, just as a whole, which may not allow them to return to their normal function and normal capacities after they've been treated. So our statistics in St. Lucia, cancers on a whole range from about 250 to 260 new cases a year. And in particular, breast cancer, maybe 50 to 60. But we are seeing an increase in that number. To dispel one of the myths that a lot of people think, it still remains more common in the over 50-year age group. So a lot of people think that younger women are more common in terms of having a diagnosis of breast cancer, but that still remains not true. But we are seeing an increase in the number of younger women getting breast cancer.
How old is the youngest breast cancer victim? What word should I use?
Right,
who you've
that I have
encountered
seen.
in St. Lucia?
The youngest was probably 25.
20.
But I did have a 16-year-old who had a precancerous lesion. So she was treated, and she's well now. She has 2 kids. She's probably in her 20s now. But at age 16, she had precancerous lesions of the breast, which we had to remove. And thankfully, her cancer was one of those that once you treat it, remove the area or the lump, then it does not progress, or there should be no progression to full-blown cancer.
And on that topic, what type of cancer is that? Can you distinguish between someone who can just pretty much have the cancerous lump, so to speak, excuse my non-technical jargon,
That's fine.
but to have the lump removed and then they're fine, as opposed to someone who has the other
Yes, so which is why there's such an importance in biopsies, right? A biopsy is getting an adequate piece of tissue that we send to the lab so that the pathologist can look at that specimen under a microscope, can identify the cancer cells, can tell us what type of cancer. And there's a lot of information that you can actually get from getting one small piece of tissue. There are different types of biopsies, but we tend to focus on the one that gives you a little chunk of tissue, because you can do all the tests, special tests like, and I'm using a big word, immunohistochemistry, that will tell us, in particular with breast cancers, if it's sensitive to the hormones or not, which will influence your treatment. So yes, we can determine the type of cancer you have. We can determine if you have a precancerous lump. We can determine if your lump is not cancerous at all, and determine how we're going to move forward in terms of managing it. So biopsies are a mandatory part of us making that diagnosis. So what one of my lecturers used to say, it may look like a duck, it may quack like a duck, but until you test it, it's not a duck, right? Okay. So back 40, 50 years ago, we would look at patients, look at their mammograms, examine them and say, this is most likely breast cancer, and start your treatment. But in the 21st century, nobody's going to do that unless we have that piece of tissue and the results on a piece of paper that confirms that you do have breast cancer or any type of cancer.
Now, speaking of lumps, because some of us, and I mean us, including myself, may have a lump that may be worrying.
Right.
And I have one that I've checked a couple of times, and they're like, oh, it's nothing, it's nothing. Are there benefits to still? So I've had an ultrasound because I choose to check on it in that way. I've had two, and it says that it's nothing, but could I, if you were my doctor, or if, or is there any benefit to still having a biopsy taken? So that again, my answer is going to start off by saying that for each client that presents to the doctor, the advice that we give is probably going to be individualized, right? So for example, like you, I had a lump in my right breast from I was at school. And when I went to my consultant, he was like, well, it's nothing. We did a little needle biopsy, not the one I was talking about, and it was like, oh, benign normal cells, and I just left it alone. Until I got a little older and realized it was getting a little larger, and I was like, okay, maybe I should take this out. Usually, if you have something that's cancerous, it's not going to sit down and just look at you for 10, 15 years and not do anything different. There are some precancerous lesions, like the one I was speaking about with my 16-year-old patient, where we know that 4 out of 10 cases will go on to develop full-blown cancer, but the other 6 out of 10 we're not sure. Nothing will probably happen. So my advice to persons, especially if you've had this lump in your teenage years or your 20s, is remain the same. You've been checked out by a doctor, maybe just like you said, had an ultrasound done, and it's remained the same. You probably do not need to have a biopsy done, okay? However, if you have a strong family history of cancers, if you smoke, all of those other associated or risk factors that we know of, my advice to you might be a little bit different. If you're also the type of person who is very keen on your breast exam and your health, and every month you make sure that you're examining, you know for sure nothing has changed, it hasn't increased in size, and you can tell me that, then my advice to you would probably still be the same, right? We can watch it, there's no need to do a biopsy. But I have so many patients who walk in and like, I don't know if it has changed, I don't never check my breast. So if I see you for the first time and we discover that you have a lump, but you can't tell me anything about this lump from before, I'm going to treat it as a new lump, and I'm going to say, hey, we need to get a biopsy or remove it and get it tested. So it's all in context. Certainly, like a lot of things, there's a knee-jerk reaction from us as physicians, as well as the patients. There's a lot of anxiety. We don't want to miss a cancer, and you don't want to be saying, I came to the doctor, they told me everything was fine, and now 2 years later I have something wrong with me, or I have breast cancer. So we, I think, inherently tend to over-treat and over-investigate so that we don't miss anything. But the majority of lumps are actually not cancerous. Oh, that's good to hear.
At the end of all of that,
yes,
the majority of lumps are not cancerous. And breast lumps are pretty common. Certainly, the younger you are, the less likely it is to be a cancer. as you get older, we spend a lot more energy and effort making sure it's not a cancer. But even in a 90-year-old who presents with a lump, chances are it's not going to be cancerous. But if you compare that 90-year-old to a 16-year-old who comes with a lump, if you had to pick which one would be cancer, it would be the 90-year-old. Because cancer, like a lot of those diseases that we speak about, has been regarded as a chronic disease, a non-communicable disease. So we hear about NCDs all the time. We hear about diabetes. We hear about high blood pressure. And cancer is thought to be one of those. So whatever is happening to the body and the cells, most times doesn't happen just like that in one go. You don't just develop cancer in one go. It's taken years for repeated things to happen to cells that actually develop into cancer.
Speaking of which, what are some, especially in the St. Lucian context, what are some of the biggest risk factors that you've seen?
Unfortunately, we don't have a lot of research and data that point to particular types of food, like specifics or particular areas in St. Lucia, which is, again, the importance of doing your own local research, right? So whenever we try to collect data, we try to see where all of these clients, patients are coming from, so that we can move on and say, okay, if they're all coming from up north, is there something up north that exactly? So we don't really have that data. The last set of data that we collected, 2014 to 2018, and that's the Cancer Society in collaboration with epidemiology and the Ministry of Health, suggested that a lot of the cancers in general, not breast, just general, were coming from Babonneau and Gros Islet. When you speak to the layman, they say, oh, Dennery, those other parts have a lot more cancer. The research that we collected did not suggest that. But the risk factors that we know that are associated with breast cancer would be things like a lot of lifestyle influences. So top of the list, we talk about smoking. Unfortunately, alcohol, including a glass of wine, is somewhere there. So even though the increase in your risk for getting breast cancer is not huge, there is a slight risk just for drinking alcohol, even if it's wine. So the red wine on the one hand, protective of the heart, but alcohol in terms of cancer risk, and breast cancer is one of those. Let me divide your risk factors into things you can change and things you cannot change. So certainly the things that we can change are lifestyle things. So as I mentioned, smoking, alcohol, exercise. I strongly believe stress levels tends to be the icing on the cake, because I really think it affects our immune system, which is usually our first line of defense when it comes to a lot of diseases, and cancer is no different.
Yep. So I saw these two images, and I'll try to find it so we can put it up. And this lady had a thermography, it's called?
Thermography.
Yeah. So she had it done, and there were lots of lumps, and, you know, she divorced her husband around that time. Within 3 months, she went back, and it was almost completely gone. So that really left an indelible mark in my mind about how impactful. I mean, we know, we've heard growing up, stress kills, but I didn't realize that it was such a literal thing. So as a doctor, how do you navigate? Because a lot of the time, like, how do you say to your patient, your man is stressing you out, or your children are stressing you out, or you need to leave that job? I mean, how do you navigate these discussions? Because I'm sure there's still a lot of people who don't realize how impactful those stresses in their lives are.
So unfortunately for those of us who have, like me, a general surgeon, yes, I have the conversation in general with my patients, just for other things not related to cancer. And I always ask about stress, the general environment, even things like what you have for breakfast. Do you eat breakfast, right? Just to get a general sense of my patients. But I see a lot of these patients with cancers when I make the diagnosis. So the damage has kind of already been done. And what I tend to focus on a lot is trying to see if there is actually a stressor or something that may have influenced. And like we said, it's nothing that happens now for now. It's something that you've probably been exposed to for a while. But with stress, it just really suppresses our body's ability just to deal with things in general, just because of how stress impacts the body and body functions. So having made that diagnosis with patients, clearly part of the treatment is going to be removing whatever the stresses are. But a lot of our patients, and I can just imagine if I get diagnosed, God forbid, my focus is not going to be on trying to get rid of the stressor. It's going to be on what do I need to do to get my treatments to get through that. So a lot of times the stressor or the things that are stressful kind of get put on a back burner until you've gotten through the initial, okay, I need to live, so what do I need to do? But it really has to be a part of the conversation. And to directly answer your question, counseling, psychotherapy, those things are actually part of the treatment, the adjuncts that we add to the management of a patient. And in St. Lucia, we still have a lot of hesitation when it comes to counseling, because like, I'm not mad, you know, it's not about madness, it's about coping skills. It's about...
Tell me about it. I've told this story many times on the show where I decided that therapy would be helpful to me because I was getting so many conflicting, you know, ideas as to what I should do, because I would ask my mom and I would ask this person and that person, and someone whose friend's daughter had just come back from university. He said, oh, my friend's daughter's just come back, maybe go talk to her. Next thing I'm hearing about myself is that so I know firsthand the stigma that is attached to counseling and going to therapy and you know, I mean, we've come a long way since then because that was over 20-something years ago. But
it's still not the natural conversation. There's still a lot of hesitation. But we do consider that that is really an important part to it, whether it's for the patient themselves or for the family. Because remember, the family has a huge burden also to be part of this whole journey.
Exactly.
Right? The spouse, the kids, there's the fear that, oh my gosh,
am I going to lose my wife or my mom forever?
Exactly. And I think that's usually the first emotion that people have to deal with. And I've said it's a good thing that when we speak about breast cancer, although men have their own set of cancers, that, you know, it's women who have to deal with it, because there's so much, our attitude is so different. It's like, we need to fight this, so doc, tell me whatever it is that I need to do so that I can move on and we can, you know, as compared to, I don't really want to have to deal with this. I'm not going to do anything until the last minute. So yeah, but definitely the mental health aspect of it, and stress, I have found that there's almost always a stressor.
Yeah. On that note, we will be right back. This is The Wellness. My name is Candy. We're here with Dr. Tamara Remy. See you on the other side of the break. And welcome back to The Wellness. My name is Candy Nicholas. If you're only now joining us, today our guest is Dr. Tamara Remy. She is the president of the St. Lucia Cancer Society. She is a general surgeon. She is a member of the American Society of Breast Surgeons. And today we're speaking about breast cancer, especially in a St. Lucian context. But speaking of in a St. Lucian context, how do we compare, do you know, to other Caribbean islands in terms of numbers and risk factors and all of that stuff?
I think we're pretty similar. We're pretty similar. I don't have the exact numbers in terms of number of new cases every year, but breast cancer is #1 throughout the Caribbean.
Oh, wow.
In terms of females. You asked the question about the #2 cause of death in general. I'm not sure what that is, but even though we're speaking about cancer, the deaths from heart disease, high blood pressure, diabetes still are way exceeding us in terms of cancer comparatively. So the majority of deaths are still secondary to those other non-communicable diseases.
I had Dr. Belmar, our chief medical officer here recently, and I think the statistic was that 82% of deaths in St. Lucia are
because of NCDs.
Lifestyle related.
Yeah.
If you could wave a magic wand as a doctor and fix things, what are some of the things that you would want to see change in terms of how we're living?
I would start with our kids. And that's where I always start the conversation with prevention. I think if you look at our kids today and compare them to when we were kids, there's some striking differences. The first one is our kids now, a lot of them are overweight. And the figures for the Caribbean are 1 in 3. 1 in 3 of our kids are actually obese. That is startling because it usually means that 1 in 3 of our adults are going to be obese too. And we have been seeing a shift from the NCDs, which we see as you get older, 50, 60. We were noticing that 20-year-olds, 30-year-olds were developing diabetes, the type 2 diabetes, not the ones that you're kind of born with or because of what's happening with your pancreas and the need for insulin. But we're also seeing a lot of these changes in 11 and 12-year-olds. So when they're 20 and 30, their bodies are going to be like 50 and 60-year-olds. So that's the first thing. In terms of prevention, I think it's way too easy now. And yes, I understand the cost of living. I understand that everybody has to work hard. I understand that we have younger and younger parents, younger and younger grandparents, and everybody's still working. But we've moved away from activities, physical activities. We've moved away from a lot of home-cooked meals. Everything is instantaneous, right? We will stand or drive and stay in a line to get food almost every day. When I was growing up, once a month, if I behave myself, I might get pizza.
Exactly.
But now it's a regular thing.
A treat, not
exactly.
a habit. Yeah.
My daughter's like, "Where are we eating?" I'm like, "What? No, we're cooking." So I would start with that, like the educational part of it. And as a St. Lucia Cancer Society, we do have programs. Of course, we need the volunteers to go into the schools to teach kids how to read their labels, how much sugar is in the drinks and the food that they're eating. It's a lot more difficult to calculate how much salt and trans fat and those things are in the foods that we eat. So I would start off with that. The physical activity for sure. Your phone and your fingers don't count as physical activity. Our kids need to be outside. They need to be walking from one place to the next. Physical education needs to be a huge part. Extracurricular after school activities need to be. When we get to secondary school, I was trying to remember if PE, when I was at the convent, stopped at Form 3. It probably did, but we played netball, we played volleyball. There was always something to do. So that, I think, is going to be the biggest influence in changing what the figures look like, whether it's cancer or the other NCDs. And interestingly, we were speaking about lifestyle and risk factors. The conversation for most of these NCDs is the same. It's the same risk factors, lifestyle, you know. So you don't have to have separate campaigns to deal with each one.
Because
you can put all exactly.
They're
you tweak
all
a little
approached in the
bit.
same way.
Exactly.
As Dr. Mark Hyman, who is a functional medicine doctor who I look up to, and I read a lot of his books, listen to his podcast, he always says that all of these are different branches of the same tree.
Exactly.
So, diabetes, hypertension, cancer, a lot of these things could be dealt with in pretty much the same way, using the same approach.
Yep. And the other thing would be what we sell as food, invest more in local produce, make the prices more acceptable and accessible. You go to the supermarket, I can't tell the last time I saw local lettuce or local tomatoes or any of these things. You go and the shelves are empty.
Yes.
And everything is imported. And I'm just like, okay. Like, to me, from a Caribbean country, it just does not make any sense to me, at least for those things, fruits and vegetables, and we've had a conversation about things being seasonal, and I'm like, why does it have to be seasonal? I mean, I get some of the science behind it, but our climate isn't that different throughout the year. So we must have bright minds in agriculture who should be able to give us fruits and vegetables, whether it's, different ones. When it's mango season, I keep looking and going, why are there so many mangoes on the ground? Like, can somebody not pick up all of these mangoes and do something so that we have mangoes? So those are the conversations, but that requires like a national government kind of input. I know I'm also one of the board members of Healthy Caribbean Coalition, who through the region represents a lot of the civil society organizations, and they've been embarking on things like nutritional policies at schools, eliminating trans fats and sweet sugary beverages. But there's only so much you can do as an advocate. The policy has to come from the powers that be, because we can jump around and say no in schools, but unless there's a piece of paper and a cabinet conclusion that says this is banned in a school, this is banned in a supermarket, your labels have to say what's in the food that we're serving you, then your effect is going to be very limited. So those two for sure. Physical activity, I see that NIC has been, trying to put different gyms and stuff in different places. Security is a big issue, because a lot of us want to exercise, but the fear sometimes the time of day to be out on the road or out on the beach.
Yeah.
So again, it has to be a holistic kind of plan.
And I never really, I have thought about it in that way, but you're just drawing a way clearer picture for me, that what we eat depends on what's available to us, and what's available to us depends on what we grow and how we grow it, and its availability, and even how it's grown as well.
Exactly, which is a big thing, huh?
Yeah, the fertilizers and other chemicals that have been shown to be harmful, are we still using them? Because I can eat lettuce till I'm blue in the face, but if it's covered in harmful pesticides, then
exactly, I'm going to die anyway of cancer.
Exactly,
that's a very important
and
component.
then security as well, because at a certain time, unless you live in a gated community or you have a gym right there at your disposal, you have to wait till a certain time to go out on the road, and even then, if you do, you're not guaranteed to not be bothered by someone. So yeah, you're right. It's a conversation that has to be had on so many levels, and so many people need to come together. And at the risk of sounding like a dictator, I've always said that a lot of people, in my experience, talking to people about wellness, they want to do better, but they don't know, as you said, how to read a label, or they think something is healthy. Like, I'll have a conversation with someone about, okay, so what do you eat for breakfast? Oh, I had a good breakfast. I had eggs, I had bacon, I had bread, because in their minds they had a hearty breakfast, so therefore it was
important too.
Yes, so therefore it was a breakfast that was good for them, and that's sometimes not necessarily the case. So it's not that people don't want to do better, they don't know how to do better. And I think that if I were one of the policy leaders, I would, as you said, effect change from that level, because sometimes we have to be protected from ourselves.
Yes,
exactly. And people may push back at first, but I think if education campaigns explaining to people why these decisions were taken are done, then you could have the buy-in that you need and see. And then even things like home gardens. I remember when I was growing up, there was a campaign to get people to grow a lot of their grow stuff, whatever
stuff. Exactly.
What happened to that?
Well, the last time that we had backyard gardening was when there was COVID, and I really thought it was an opportunity to maintain that, because even when my daughter was at school, I was pushing and saying, why don't the kids learn how to grow their own herbs and veggies? And you have a farmer's market so that they understand how they're linked to what you eat every day, your salads, etc. But I don't know. We tend to be very reactive as a society. Yeah. So when there is an emergency where we no longer have access to food, then we come up with all these bright ideas, but it's usually in reaction to something. Our food security, I think, needs to also be on the top of that list, because any natural disaster, anything can happen, and we are stuck again with where we're getting food from and at what cost. So those are, I think, excellent initiatives. In Antigua, especially during COVID, the government bought seedlings, etc., and handed out to the public.
Oh, wow, that's amazing.
Yeah, so again, and it's the continuation. So we're having this conversation in October, and I can guarantee you that October 31st, or even before that, because there's Journée Creole coming up this weekend, breast cancer, where there was so much pink and so much awareness being created, was a thing. And come October 31st or November 1st, it's like, okay, we're on to something else. And that's like the rest of the conversation
so the pink ribbons are going to turn to bad dress, and then we're going to be eating all those trans fats and all of the hype.
And then the rest of the year, nobody remembers
and
that
then
there's
Christmas
breast cancer.
Comes around.
Exactly. There's always a reason. So I think we just need the things that we all deem as a group important. And I'm not saying it has to be breast cancer. We need to have the continuous, consistent messaging. And like we try to do as a society, we try to do something well. So it may take 1 year or 2 years. You keep that going regardless of what's happening, and then add to it, add something different every year. So at the end of a few years, hopefully you have, enough programs and enough policies that we're trying to push for. But I think the holistic approach. It can't just be Ministry of Health or Ministry of Agriculture. We need to sit down and decide, okay, what's important here in St. Lucia and how are we going to tackle it?
It's something that you just said made me think of the concept of pink washing, and that's when, you know, there are a lot of companies, some of them that actually sell some of these harmful products, or, you know, the messaging just seems contradictory or superficial, or it seems like virtue signaling, because you see a lot of companies like maybe alcohol brands, or just as an example, you know, with the pink ribbon. Like, how do you navigate that? I saw this meme recently where you know, we don't want to see your pink ribbon. How about you take off the harmful substances?
I was about to say that. I saw it and I thought I was excellent.
Yeah,
I thought I was excellent. So and you know, even at a board level, I've gotten some pushback, and even from members. But for me, I'm very, very clear. I cannot, especially if I'm representing the Cancer Society. So I'm by no means perfect. So I will drink my wine and I will have some alcohol once in a while. But if I'm representing an entity, I need to stay true to what it is. So we've had activities. So in 2019, we had our Carnival band, which was a T-shirt band. And you know, members were like, but we need to get sponsorship, so why don't you get this person? I'm like, but they're not aligned with what we're about. And it took a lot for me to convince people, even on the board at the time, that you can't have conflicting messages. You can't be talking about alcohol and smoking and, you know, poor eating habits being associated with cancer. And if you take those out of what we do, there's a reduction in your risk of getting cancer. But have a sponsorship from people who do that. So for me, it's very easy to do. We lose sponsorship, we lose some of the interest, but that's okay. I think it's more important to stay true to the message. And I really and truly like that meme, you know, instead of the pink, why don't you just remove?
Help by removing some of those
causing
things that are.
And I think we need to hold a lot of these companies accountable.
So we spoke about families and it being hard, but we're going to continue that conversation on the other side of the break. I'll ask a question on the other side of the break, but you need to stick with us. This is The Wellness. Hello and welcome back to The Wellness. I'm Candy. Today we're speaking about breast cancer awareness in general with Dr. Tamara Remy. She is the president of the St. Lucia Cancer Society. And one of the things we touched on, which I would like to continue touching on just for a little bit, is how necessary it is to have a proper support system, because we always think about the person who's going through it, but their caretakers, their family members, their friends, their colleagues, everybody around them. It must be a very daunting thing to know that someone you love is going through this. So what usually is your role with, yes, you deal directly with the patient, but how has that role spread into dealing with their caretakers and other loved ones?
The patients, you know, in our St. Lucian context, as a surgeon, we are the ones who tend to make the diagnosis, right? So by that time, the patient has already formed a relationship with you, right? They've come to you with a concern. Most times you try to allay their fears while also being as honest as possible as to what this pathology might be. And certainly by the time we get to giving them a diagnosis, you know, we are the first ones to see the whole reaction of it. We have to be with them as they kind of navigate through, okay, doc, what's next? Like, how far is it? What stage am I at? My personal thing is, once I've given you your results, so I don't give results on the phone. I usually bring patients in. I tell them this from the beginning. So if my secretary calls and says you need to come in,
so good or bad, you don't give.
Exactly.
Okay.
So if you get a phone call, doesn't mean it's good. If you don't get a phone call, you know, we're not trying to guess what the results are. You're going to get called in because clearly you have something going on. We still need to discuss, regardless if it's cancer or not, what's next. So they usually come to me, and usually they're by themselves the first time. And as much as I try to say, I've just given you a diagnosis of cancer, we need to allow that to settle and sink in. And then I'd love for you to come back with whoever. You can come with 5 sisters, you can come with all your 10 children, doesn't matter.
You're good
So
with
we
that.
can go through that again and have the conversation. By that time, usually it's a few days, 3 to 5 days, sometimes by the next week. You know, when you process it a little bit, just come so we can have the conversation. You might be a little bit more receptive to all the things that have to be done. So you're almost part of the family by then, because everybody comes to you and they're looking at your face like, okay, doc, how bad is it? You know, and they're sort of holding on to your every word. So even though I have found, even though I explain to them that I'm just one person out of a few of us who will be responsible for taking care of you. I'm not an oncologist, I'm a surgeon, so I'm gonna have to refer you to the oncologist, but we will be in touch. A lot of the questions still come back to me. Even those things that I have no idea about. Like, I mean, you have an idea, but that's not my area of specialty. So I always suggest that they seek counseling. I always suggest for the actual patient, and it may be something that you're not comfortable with initially, that there are support groups that they can be a part of. They don't have to be actively participating, but they can see and listen and get a sense of what makes them feel comfortable. There's a lot of information that survivors and persons going through this can give them that as a doctor I would never be privy to. You know, little things that you can't find in a book that they've gone through.
Yeah.
And we stay out of the support groups, right? So they can bash the doctors if they want to, they can compare and contrast. But we try to make it a point that even the husband, the whoever, needs to also go to counseling and try to prepare them for what's going to happen. It's a little bit difficult, I find, for men. And I can only imagine, because on the one hand, you have to be supportive. But you're also terrified for several reasons, you know. I believe that men are certainly more, what's the word I'm looking for? Not sensitive, but a lot of physical attributes are more appealing to them. So they will probably love you to death, but the effect of you losing a breast or losing your hair, we kind of take for granted.
How do they deal with that?
Well,
because
that's
you
the
keep
million-dollar
hearing, I mean, I
question.
don't know how accurate that is, or if that's just something that we've said for many years, so we just keep saying it. Men are visual creatures. Men are visual creatures.
They are.
They are.
They are. And I think they function better in a space where they can be honest about the feelings. If you're sitting with your wife, like you go to counseling together, you're almost feeling obligated to say, it's okay, my dear, you know, it doesn't matter if you lose your hair, etc. Like, I want you to focus on you and what the treatment you have to go through. We have our life together. Like, that's not going to make me change how I feel about you. But the reality is, a lot of times it is. If you're in a space with males who are going through, who have partners, you're almost much more comfortable to say, oh my gosh, like, it doesn't detract from how you feel about that person. But it must be, because as a female, when you look at yourself in the mirror with one breast, you already have so much to deal with. So far as and you know why you had to do it, you know what you've gone through. But you just imagine a partner who's never seen you like this, having to deal with that. So it's different dynamics, and I don't know that we have a lot of safe spaces where partners, etc., can actually have those honest conversations and actually get counseling how to deal with those things. But I think I'm aware that it's something that we don't think about because we expect everybody to sort of just be supportive. And from a survivor point of view, which again takes us to October and how different people actually view October. So for those of us who are trying to advocate and bring the awareness, we're all pink because it's commercial, it's a nice color, and you know that people will support pink. But we also have to remember the survivor who's gone through it. They're like, I don't want to talk about pink. Like, I don't want to see pink.
Yes, this
it is
must be very triggering for some
exactly,
people.
for some of them.
Yeah, who've been through it.
Or even relatives, somebody who died from it, who didn't survive.
Yes.
And even for survivors who might have gone on this journey with friends or people that they've met along the way, and they have survivor's guilt because they've survived, but people that they knew had lost the battle. So it requires a lot of sensitivity, I think. It's not just about, like we said, commercializing breast cancer and pink and trying to raise funds. Those are important, but it's also the significance of why we're doing pink. To honor all of these different persons, the survivors, to remember those that we've lost. It's a lot more encompassing than just, you know.
Are men with breast cancer also part of this month's observance, or
Yes.
they have their own?
No, it's usually
Okay,
should
so it's
be
for all breasts.
it's for breast.
Okay.
Yes. It is. But we tend to forget the men. Like we always say, yes, 1 out of 100 will be a man. In my practice, and I've been a surgeon from 2007, I've probably diagnosed 3, maximum 4 men. Everybody else has been female.
And what does it? What is the difference? What does it look like for a man who is diagnosed with breast cancer? How different is it to a woman dealing with a diagnosis and treatment?
First of all, they're in shock because it's like, why do I have breast cancer? Like, I do have breast. The main difference is how easy it is to pick up an abnormal lump in a male breast. Because most men, not all men, have flat chests. So if you have a lump or something is happening or you're having discomfort in your breast, you're going to go to the doctor because this is not normal. And it's not like you have to go looking for it. It's right there looking at you. The treatment is the same.
Okay.
Yeah, the outcomes are the same. So the same chemotherapy, surgery, remove the breast tissue, it's the same. Treatment for treatment is the same for both. And so maybe not as devastating because you don't have that much to lose in terms of
because
the
you're
actual
pretty
breast.
flat-chested.
Exactly. And if they really want to, they could probably get nipples tattooed if they really wanted to look like the other side. But yeah.
2 things I've seen you advocating for online are women embracing their scars, or people embracing their scars, and the formation of a cancer registry, a breast cancer registry. So let's touch on those 2 things. So how does one embrace such a horrible scar? How do you get to that place where you are comfortable with it? I mean, I've seen some lovely pictures of women showing off their scars, and I see strength and resilience and all of that wonderful stuff, but it must still be a journey to get to that place of accepting that, okay, this is what my body's going to look like now.
We have to divide our patients into 2. So I have patients who are very attached to their breasts. I have had one patient who said, you can take off my breast, it's fine, I'm not doing chemo. Forget that. And then I have other ones, I could do the chemo, but I'm not taking off my breast. Like, I need my breast. The majority of my patients, though, are like, Doc, I don't want to have to think about having to examine this breast again. I don't want to think about whatever you leave behind having cancer again. In fact, can you take off both? I'm like, no. Somehow, actually, nowadays have the conversation a lot more. Patients are like, can't we just take off both so that I don't have to deal with breast cancer ever again. I mean, there's no 100% guarantee if you take off both of your breasts. There's still some breast tissue, right? But the risk is certainly reduced significantly. But the mentality I find of a lot of our patients is take it off. Just take it off. I don't know if there's a lot of influence, and I suspect there is some influence from the fact that if you have breast conservation or lumpectomy, where you just remove some of the breast and leave back the rest, you have to have radiation, which means you need to travel overseas because we don't have radiation here, and it's going to be for 4 to 6 weeks, and it costs money. That's one. The second is a lot of our patients present fairly advanced, and so breast conservation or anything short of removing the entire breast is not part of the treatment. Like, you can't really realistically offer them that. But I found that the attitude is, that's okay, this is what I have to do. If I have to choose how I look versus life, it's an easy choice. And I think that's the mentality. But I do recognize that there are some women where they're younger, their breasts mean a lot. It's a sign of their womanhood, femininity. And they have a lot of struggles with just visualizing themselves. But I think at the end of the day, the most important thing for a lot of women is the fact that I need to do what I need to do in order to survive. And even though in a lot of first world countries we have reconstruction, whether you do it at the same time as removing the breast, you get a nice tummy tuck and you can get the muscles. A lot more women are actually opting for flat chest, even though they have those options. And I think a lot of it has to do with the anxiety that they get from putting in a breast implant or reconstruction, and just not being able to feel for lumps, like not knowing what's going on. They go crazy. They're like, doc, I've had a few patients say, can you take it out? Can you just take out the implant? Like, really? I don't know what's going on. How do I examine? Which test am I supposed to use to make sure it's not going to come back? But if you look at the figures, if you look at the statistics, even in the United States, where they have just about everything at their disposal, a lot more people are actually opting not to have implants done.
Yeah, I think there's been a big conversation around breast implant illness lately. Maybe not just lately, maybe longer than just lately. It's been going on for a while, and I could see why and how that would be that would be the case.
A lot of our women are like, I just stuff my, whatever is there, just stuff it, and it looks the same, or I get the real implants for the bra, and it looks the same, doc, I'm fine, just take that off, So it's almost like a cesarean scar. A cesarean section scar, and our stretch marks, those of us who have stretch marks, I don't think I have any. But you have a family, you have children to show for it. You've gone
so it's
through
a sign
this,
of something you've gone
and
through.
You've gone through this journey and you've survived it. I think it really shows a lot of resilience. On the other topic of the registry, there's absolutely no way that you can design policies or even set guidelines in any country if you don't have figures, if you don't have statistics. And the registry doesn't just look at the number of cases or the types of cancers. So our cursory, very crude registry that we've done has been able to show us and confirm what we've been thinking, that the top 5 cancers are prostate cancer, breast cancer, cervical cancer, colon cancer, and skin cancer, as much as
just about to bring
skin
that
cancers.
up,
But most places don't discuss skin cancers so much, because once you remove them, that's it. They're unlikely to cause death. So at the registry, or at least the information that we're able to get has shown us that. But the missing information is going to be, where are the most common cancers coming from? We were able to get the age groups. That's initial. But the value of the registry is also, at the end of 5 years, how many of these patients are still alive? How has their access to healthcare been? What are the things that have influenced how quickly after diagnosis they can get treatment? What are the factors that influence the consistency of their treatment? Is it cost? Is it where they live, right? Is it public versus private? And how do our treatments compare to the guidelines that are available online everywhere else that everybody follows? Are we adhering to those? And what's the audit? So at the end of 5 years, when you talk about stage 1, which is a small lump in your breast, the survival rate should be 98%. In St. Lucia, what's our survival rate for those patients who present with stage 1 disease and stage 3 disease? And it will guide us as to, okay, do we need to do better at screening? Do we need to make mammograms more accessible to people, or tomosynthesis, or do we need to change from mammos to MRIs? Do we need to, how are we changing what it is that we're doing? Do we need to make chemotherapy more affordable? Do we need to put a separate budget, because we can calculate how many women are between the age of 50 and 70, if that's the major group that's developing cancer? How many will require this type of chemo? How much is it costing us? You can budget, you can do a lot of things. And so it's absolutely essential to have a registry. If you look for funding, if you look for grants, if you look for research, you have to have a baseline. So I'm not sure where we are with the registry.
So what's getting in the way of that happening?
When
or are we going to throw some people or organizations under the bus?
Well, I think they're accustomed to me. So we at the Cancer Society, I think that's our biggest contribution to date, was to at least collect that initial data.
Okay.
And we did that in collaboration with epidemiology, because we would not have, I'm not a statistician, so I don't know anything about it. I can plug it into Excel and get some graphs and be like, okay. So definitely epidemiology. We had signed a memorandum of understanding so that we would have worked together, but when that expired, I really don't know where it is that we are now with the registry. I still collect data. I still collect the crude numbers.
So at least you
So
can
at least
make
I
your
can
contribution.
say I can do that. But in terms, it's going to require an actual team. It's going to require funding. It's going to require dedicated service to do that. We are using lab-based material in terms of creating this registry. And that's easy for us because we have 3 labs that you can collect that data from. Like one of the labs must have diagnosed the patient unless you're coming from abroad as a St. Lucia with your diagnosis already. So it's a matter of enacting our Health Act, which makes notifying about cancers mandatory. So if you've made a diagnosis, you're supposed to notify the ministry and let them know that you have a patient with cancer. And really just ensuring that as physicians, even simple things like filling out the forms completely. So when we collected our initial data, we're only able to do 60% in terms of where patients came from, because that information was missing on a form.
Like where they came from.
So like their address.
Oh my
So we
goodness.
put the name, maybe the date of birth, maybe the age, all of that information, and some parts are missing, so you don't have complete forms.
Okay, so that's why there's this discussion about whether it's Babino or January or
exactly.
Oh dear.
Right? So you need to have everybody on board. So it's not impossible, it just requires commitment and some dedication to doing it. But it also requires some training. So I'm hoping, since cancer is such a big thing in our society, it's not the largest group of patients, but the impact of that group of patients. They're out of work for a period of time. The mortality, the deaths associated with cancer should make it a priority. And unlike diabetes and high blood pressure, you kind of have to find the money and do the treatment in 6 to 8 months.
Yeah.
Like it's just
You
at you.
yeah.
You don't have once a month, trying to get medication. You have to find the money. You have to do all these tests. And most times you can do it as an outpatient. So it's not like you can be in the hospital. The hospital will pay for the stuff, and afterwards you can pay for it. You can be home.
So speaking of which, what are the major differences between the care for cancer that's available publicly in our public healthcare system as opposed to what you can access privately?
There isn't that much of a difference.
No?
There isn't. I must say, though, that if there are differences, sometimes it's the timing of treatments because of volume. Sometimes there are some delays in terms of procuring some of the medication, but we do have pharmacies that are public and private. So if the public pharmacy doesn't have, you can get the medication, which you can get instilled in the public sector. Usually it's the same doctors who work public and private. And I've been stressing that this year especially, that is not such a big difference. Privately, it'll probably cost you a lot more for some of the same medications. Sometimes you pay for the convenience of being able to start your therapy next week as compared to the next 3 to 4 weeks. And that's fine. But in terms of imaging, in terms of diagnosis, in terms of getting seen by the oncologist, I don't think that there is a huge difference. But certainly persons who are able to afford private care can probably write a check and get their medications ordered, right? Even though it will cost them more money. And so even though the drugs and medications are cheaper in the public sector, same medications, $500 to the regular person for a course might be a lot more significant to $2,500 in a private setting to somebody who can afford $2,500. So it's not necessarily the availability of the medication, but the pocket that it's coming from to pay for the medication. And we don't have a lot of lending or fundraising or donating agencies who can readily give every single patient the full cost of their treatments, right? And so that limits people. The other thing that I think limits people is a lot of persons do not have private insurance. Yes, everything is out of pocket. So if you don't have the money, you have to wait until you work a certain amount of time to get paid before you can pay for your treatments. And so that's really a limiting factor. So the things that we need to do individually in case we get any of these chronic diseases, so that at least we have access. And yes, there is more that our governments and different persons can do to make a more smooth running of oncology services in the public sector. But I think we've made a lot of progress in the last 2 to 3 years in terms of appointments to oncology, medications, procurement, etc. That is really should not be that vast a difference
between them.
Between the two.
Okay. Well, on that note, we're going to take a quick break, and when we come back, we are going to wrap up. This is The Wellness. I'm Candy. Where's Junior?
There you go.
I guess he'll edit that. Welcome back to The Wellness. My name is Candy, and we've been having the most enlightening discussion about breast cancer and breast cancer awareness in general, especially in a St. Lucian context. We can read a lot of things online, but a lot of it does not necessarily apply. A lot of it does, but a lot of it does not apply to our specific situation here in St. Lucia. And helping us to do that today was Dr. Tamara Remy, who is the president of the St. Lucia Cancer Society. She's a general surgeon, and she's just been enlightening us. There are some, as we wrap up, some lesser known factors that I want to touch on. So one of them I came across was night shift work because of how it affects your circadian rhythm. Have you had any patients or seen any patients who were night shift workers and believe that that affected their risk?
It becomes a little bit difficult to pinpoint it, to that alone. But yeah, I do know that night shift, how it affects your circadian rhythm, it has been thought to contribute to cancers and breast cancer. But I'm not sure in St. Lucia, because we do have shift workers, we do have clients who are like hotel workers, etc. But I don't know that the majority of them work a night shift. And if that's the case, I have to go tell all my junior doctors that they cannot work on call. They're putting them at risk.
Yes,
but
yeah. I mean, we're so thankful for night shift workers because we need them for,
Definitely.
The world to continue as we sleep. So when we wake up, things are happening. But I guess it's good to be aware of, so you can take precaution and do other things to
limit.
Higher density breast.
Higher density breast limits our investigations. I think that's where
it becomes
the risk factor.
Okay.
So there, when we use the mammogram, when we use an ultrasound, when we use this new 3D mammography or tomosynthesis, being able to see abnormalities in a very dense breast becomes more difficult. And so there's probably a delay in being able to make the diagnosis.
Okay,
it also makes it difficult when you do your self-breast examination to determine what is what, and that applies to patients who also have very lumpy breasts. So you need to be intimate with the breast so that you know certain types of your cycle, what changes after the cycle, what's supposed to happen, which areas are lumpy, which areas have small lumps. You really have to pay attention. And I say to my patients, if I see you once a year, like for your annuals, I'm not going to remember what your breast felt like last year. I mean, if you came with 3 breasts, I would remember that for sure. But apart from that, so you were really the key in being able to see if something has changed.
So guys, we need to be, participating in our own health care as much as possible. We can't expect magic when we go to the doctor. So alcohol consumption, you touched on that earlier, but what exactly about alcohol consumption puts us at higher risk?
I'm not sure exactly the mechanism for alcohol as it pertains to breast cancer. Certainly things like liver, but not even so much cancer as for just destroying the liver and the liver function. So I'm not sure exactly how alcohol works, but we do know that 1 glass of wine increases your risk by 0.0. It's smaller, it's small, but the more glasses of wine you have or alcohol, the higher the risk goes. But I'm not honestly, I'm not exactly sure how alcohol but it is a risk factor.
Okay. So use of personal care products. Now, sometimes I see, I watch all of these get ready with me videos and people are slathering and lathering and, it's just one chemical laden beauty product after another. And I don't mean to be a hypocrite. I'm a beauty product junkie. I love my creams, I love my lotions, I love my potions, but I'm very selective.
Right.
What I buy, what's in it. But especially with young, a lot of young girls, they're now, because of social media, getting into this whole, beauty, and using products they should not be using at a certain age. So how do you advise your patients about what stuff they can use in their homes, on their skin?
Right. In terms of, so there are all these different long names of different things that are supposed to be associated, certain types of fragrances, not just breast cancer, but cancers in general. Even so much as the types of color that people put in their hair and relaxers, etc. The one that I think is probably most applicable to breast cancer, which I keep getting asked all the time, and unfortunately there's no research that supports it, is the use of deodorants. And which deodorants should be avoided, if they should use deodorant at all. So up until now, the research has not seen a direct link between deodorants and breast cancers.
And that's aluminum containing.
Exactly,
Yeah.
right?
Yeah.
However, I don't use deodorants with aluminum just because.
Yeah,
Because I
just
know
to
that
get it-
medicine research changes so often. There is no doubt that the majority of breast cancers happen in this portion of the breast, the outer quadrant, which is close enough to the axilla, to the underarm. And I think it just maybe has to do with the drainage. I don't know. And when we speak about risk factors and cause and effect, we have to be very careful, right? So there are very few things where we can say, because you had this, it caused that. That's why we use the word associated or risk factors. So yeah, it puts you at risk, but it doesn't mean that everybody who uses it or who does it is going to end up with cancer. That's a cause and effect. So when we talk about HPV, the virus, HPV virus, we can say that some persons who have HPV will go on to develop cervical cancer. So the cervical cancers that we've seen, 95% of them are related to HPV virus. 95%. So cause and effect, because there are lots of people who use deodorant who will never, ever, ever get cancer. Likewise, as much as we speak about smoking, as much as we speak about alcohol, a lot of people who smoke who will never develop breast cancer. So it does not mean that because you're doing it that you will get it, but it increases your risk. But we don't know how. We don't know if it's 10 cigarettes a day as compared to 12. That's going to be like that tipping point, that trigger.
That's the thing. And what you're speaking to is what one of the naturopaths whose work I follow closely calls, the rain bucket theory, where it is believed that, let's say I have my bucket, you have your bucket, and the more things that we put in there, eventually, it's going to start to leak, which is when you get those diseases. So you may say, but I smoke or I drink and I'm fine, but your bucket hasn't started spilling over yet.
Whereas that tipping point is.
Yeah.
Exactly.
So I guess the smart thing to do would be to avoid as many of these risk factors as possible, because like you said, you enjoy a glass of wine sometimes, and as a good Caribbean woman, I enjoy a little drink around Carnival time or the Christmas or whatever.
On Friday.
Any day that ends in wine.
I know, right?
But what are you doing after to help your body to deal with or recover from those? One I found interesting, one of the risk factors was delayed first pregnancy or no children. And I thought that was interesting.
Well, again, that can fall under modifiable or non-modifiable risk factors. So for some persons, they can't have children. And for some people, they choose to wait and have kids. The risk factor or the cause of that or the association of that really has to do with your exposure to estrogen and unopposed. So when you get pregnant, your hormones change a little bit. There's a little bit of protection because it's not the constant exposure to estrogen. So if you've started your menses very young and had a late menopause, you have this long period of time that you've been exposed to estrogen, and that's thought to be a risk factor. So if you've never had a child, also thought to be a risk factor. Interestingly, having a child is more the advantage of having a child, regardless of your age, really has to do with the breastfeeding as well.
Yes.
Because we think that when you actually breastfeed is when your breast cells mature. If you've never breastfed, then they remain immature. And so that's a risk factor. But anything that exposes or increases your exposure to our female hormones unopposed for a long period of time is thought to be a risk factor. And that's where things like the oral contraceptive pill increases your risk of breast cancer. The good thing is that once you've stopped taking the pill, the risk goes back down to what it was before. There's a lot of debate now about hormonal replacement therapy. For those of us who are closer to 50 and going to be going through menopause, there's a lot of discussion because up until 5-10 years ago, it was a no-no. You do not take hormonal replacement therapy because you're going to increase your risk of getting breast cancer. Now there's a lot more research, and we're actually being advised that that's not necessarily the case.
Yes, I heard that there was some, there was a mix-up with the data and the sample, and it's not as harmful as it was.
Well, the thing is, when they did that study, they were not looking at breast cancers. At the end of it, they looked at effects like breast cancer, but the purpose of the study was not to look and see over 20 years, well, over whatever period of time, those persons who had hormonal replacement therapy who developed breast cancer or not. And if we look at the data, it's not uniformed. So usually when we do research, we try to be as uniform with the 2 or 3 groups so that you can't say, well, this group had more older women at that group, so you can't really, it's not effective, it's not a correct conclusion. But we have started a lot more. When I say we, the scientific community, looking at menopause, looking at hormonal replacement, because there are a few things. A lot of women are living until older. A lot of times when those studies were done, people were dying a lot younger and the endpoints were not being looked at. So we now need to look at hormonal replacement therapy and our general health, not just the consequence or side effect of breast cancer. So I suspect there's going to be a lot on that.
Yeah. Okay. Yeah, I think I was told, I was told by my doctor, like she sort of put me on alert that I may be a candidate for. Like, why are we having this discussion? Why are we talking about this? But she was preparing me for. So by the time I need it, let's see
you
what we think about it then.
Exactly.
Okay. Well, on that very personal note, we are going to wrap up. I want to thank you so much for taking time out of what I'm sure is an extremely busy schedule to be here with us today, and I look forward to having you back at some point because she doesn't just deal with breast cancer, guys. She deals with this. She's the president of the St. Lucia Cancer Association, so there's a lot more for us to talk about, including the rising incidence of skin cancer. I'm very curious about that and want to bring that information to the public and see where that's coming from. Okay, well, this has been The Wellness. I'm Candy Nicholas. Thank you so much for joining us. We'll see you next time. Bye.